Marvin Goldfried is a distinguished professor of psychology at Stony Brook University, where he helped to develop the graduate program in clinical psychology. He's the co-founder of the Society for the Exploration of Psychotherapy Integration. Alan Francis is a professor of psychiatry and chair emeritus at Duke, and was chair of the DSM-IV task force. Marvin describes the evolution of his psychotherapy orientation as psychodynamic, behavioral, CBT, and eventually integrative. He practices, teaches, and supervises what works clinically using direct and indirect evidence base. Alan describes his approach to psychotherapy as whatever works, or no one-size-fits-all. He was trained and taught at the Columbia University Psychoanalytic Center, but remains equally interested in brief, supportive, cognitive, behavioral, interpersonal, and family therapies. Please enjoy this week's episode.
Good morning and welcome to Talking Therapy. I'm here with my colleague and dear friend, Alan Francis. Morning, Alan.
Hey, Marvin.
And I'm Marvin Goldfried. And we have an interesting topic. And Alan came up with a title, but I'm not sure it was his own for today. It's called, let me read it off exactly. What makes psychiatry so mindless and psychology so brainless? That's a great title for a book. You should write a book on
it. Leon Eisenberg, it's not an exact quote from what he said, but it's about 50 years old, and we can attribute it to Leon Eisenberg, who was a great child psychiatrist at Harvard. And he said it just around the time when psychiatry was becoming very mindless, when the switch was to biological psychiatry. But he was also predicting the fact that if we lost the value of the biological aspects, we would become brainless, and that would be a problem too. So he was suggesting we should have a combined model that included biopsycho and social.
Well, what I would love to hear from you, because you were in the midst of it, of the shift within psychiatry from therapy to biological psychiatry.
Yeah, well, this happened for several reasons. It happened very dramatically. Up until about 1975, 1980, every chairman of the Department of Psychiatry was interested in psychotherapy. Many were analytically trained. After 1980, within just a few years, every chair of psychiatry was biologically oriented. Part of this had to do with the NIMH. So large grants in psychiatry began arriving in the early 80s. It's when we were on the committee, the NIMH committee that did psychotherapy research. Yeah. At that very time, the NIMH was beginning to switch focus and putting lots of money into psychiatry. So that for most medical schools, psychiatry became the second biggest department in terms of external dollars. And most deans of medical schools care most about how many external research dollars they can bring into the department. So if you hired someone who was a biological psychiatrist, your medical school would get many more federal dollars, increasing its prestige and also paying the rent.
So they weren't giving too many grants to psychoanalysts.
Yeah. In other words, we were giving out peanuts in money for psychotherapy research. That research changed the world with CBT and DBT becoming very popular. The departments, though, depended on heavy biologically oriented grants from NIMH, and therefore they hired the chairs who would most likely attract researchers who would attract those dollars.
So follow the money.
Follow the money. The other thing that was happening on a more professional line was the need to distinguish psychiatry from psychologists. So there are only about 40,000 psychiatrists. There are about 200,000 psychologists. What would be the competitive market edge for psychiatry? That we could prescribe medication. The psychologists tried very hard to get prescribing privileges in order to be able to compete on that battlefield. They largely lost. And so as a result, there was a differentiation with psychiatry using its competitive advantage of being able to prescribe meds, which were exciting at that time, new and exciting. Psychology was able to use its competitive advantage of being the experts in psychotherapy and cheaper for insurance companies if you're buying psychotherapy hours and you're an insurance company, it was cheaper to get psychologists than to get psychiatrists doing it. So they started restricting, the external world started saying, we'll spend less money per minute for psychologists to do psychotherapy, and we'll restrict psychiatrists to doing the medication management, which will be more expensive for us, but we won't give them very much time per session to do it. And psychiatric visits began dropping from the traditional 45 minutes to only 20 minutes.
I don't know if you know this. What's the relationship behind the scenes between insurance companies and psychiatry?
Oh, well, the way anyone, psychologist or psychiatrist, got paid was to have a code for a diagnosis and also a code for the services. And what the insurance companies increasingly did was require that psychotherapy services be given by psychologists and only restrict the psychiatrists to medication management. And the way they did this was to pay much more for medication management than psychiatrists could get for psychotherapy. So they made it economically disadvantageous for psychiatrists to do psychotherapy.
Oh my God. So in essence, what you're saying is that insurance companies were manipulating the profession.
Wake up and smell the coffee, Marvin.
I have it right here. But coffee says nothing about what's going on there. I mean, I knew there was all kinds of hanky-panky and stuff going on like that. But I was taught that if we did research and wrote books and gave talks, that we would influence the field. And I could just see people in insurance companies snickering at our efforts. Is that...
Well, you can't be naive about this. They were also at the same time manipulating psychology in terms of how many sessions.
Yes. Oh, well, that's clear. Yeah.
How much they would pay for the session. So that the insurance companies have tremendously shaped professional practice in both fields.
Yeah. And it changed not only what psychology would do, but how psychologists would think. And what I mean by that is you're talking about a code, right, for the diagnosis and a code for the intervention. Well, I was doing outcome research on clinical problems, such as lack of assertiveness, such as anxiety in test taking. And I got a visit from Barry Wolf, who was the staff person at the NIMH. And he said, sorry, Marv, we can't fund your research anymore. It has to be within this medical lens.
Exactly right. It actually led to the whole development of coaching, a whole discipline. It's really a kind of psychotherapy, but outside the medical system, not requiring a medical diagnosis and not getting paid for by insurance companies. The DSM method lent itself to more or less reliable diagnosis. The coding of the psychotherapy, the insurance company hoped, would lead to more or less standardized therapy. And the one result of this was that in many countries, the only kind of therapy that would be paid for would be CBT, because CBT had done the early studies showing it was effective. So it led to a tremendous change in the kinds of practice that people could do, because the kinds of practice people could do would be so influenced by what the insurance companies would pay for. And your research efforts, in a way, were used in this regard to prejudice against those therapies that did not lend themselves to research, and for those therapies that did, so that it led to a marked diminution in psychodynamic psychotherapy, because insurance companies were less inclined to pay for it, because it didn't have the research support, because it was harder to study. And even though lots of studies that compare different types of therapy, psychodynamic and CBT, find more or less equivalent results. So I don't think we should be at all naive about the impact of outside forces, especially insurance companies, in determining how people practice it, what they think, whether a patient gets medication or gets psychotherapy, how long that psychotherapy will be, that the insurance companies have had a dominant role in shaping practice on both professions.
Well, I knew that, but I didn't realize the extent to which it was happening and the extent to which essentially I had strings attached to me for a puppeteer.
So we have on the one hand, the first thing was the fact that the research dollars to medical school went to biological psychiatry. The second factor was that the insurance companies were pushing psychiatrists into biological psychiatry. The third factor was intellectual, and that is that starting in the 60s, the new psychiatric drugs came into play. We had the first members of the antidepressants, the first members of the antipsychotics.
Yeah.
Pretty soon after that, we began getting anti-anxiety drugs in the 70s. And so there's this excitement that we had a new tool of effective, and at the time it was thought maybe even specific psychiatric drugs for specific diagnoses. In the 70s, we had the invention of the MRI, the PET scan, the CAT scan, all within a few years of each other in the 70s. And this gave the sense that we could view the brain in action. We could view it structurally, we could view it functionally, and we would decide based on a picture that a computer would generate that this or that was wrong with the brain. At the same time, we had new powerful tools of molecular biology that could determine how the nerves of the brain functioned in a very sort of, very high resolution way. You could actually put a little probe into a nerve and see how it was functioning. And we had genetics coming into play, and the hope, the false hope, that we'd be able to figure out the gene for the diseases. So we had these three, all of them turned out to be flops. We had imaging, we had molecular biology, and we had genetics, all promising sudden breakthroughs in understanding mental disorder and how the brain worked. They all turned out to be very interesting intellectually. None of them really turned out to be at all useful clinically. They were all clinical flops, but they helped to legitimize, since we had these pretty pictures, since we had the gene markers, it helped to legitimize biological psychiatry. And so people went way overboard. Biological psychiatry, starting in the 80s, was way oversold and way overbought. And what it did was limit the profession much more to pill pushing.
Now, what was it like for the chairs of psychiatry programs throughout the United States that were psychodynamic in their orientation? How did they get pushed out?
Oh, it's easy. They got old. So a lot of these chairs had been the people who had led the war effort, the psychiatrists who led the war effort in World War II.
Yeah.
The exciting new model. The psychiatry before psychodynamic psychiatry had very few tools. Psychodynamic psychiatry was very intellectually and clinically exciting. The only psychiatry general in World War II, Bill Menninger, was psychodynamically friendly. And most of the people who were exciting in psychiatry after World War II were psychodynamically oriented. The departments of psychiatry in American medical schools didn't develop until after World War II. So there was not a separate psychiatry department in America until there were a couple, like at Hopkins and Columbia. But for the most part, the separation of a department of psychiatry was a function of World War II and these new bright people coming into the field. And so those people by the 1970s or 80s had aged out. And they were replaced by much younger people who had come up in the new tradition. Many of them had spent time at NIMH.
But were these people immigrants from Europe?
No. The first group had some combination of immigrants. The psychodynamic group had some combination of immigrants from Europe, but mostly American born. The second group was almost strictly American-born biological psychiatrists. Most of them, again, had either training in the few biological psychiatry-oriented departments or had spent time at NIMH. And then the result was that there was a kind of split. There were chairs like myself who were very interested in psychotherapy as well and felt that psychotherapy was part of every doctor's toolkit. So some of the biologically oriented chairs were friendly towards psychotherapy and had pretty extensive psychotherapy training programs, even within a biologically oriented department. Others went straight more towards descriptive and biological psychiatry, and some were completely hostile towards any idea of psychotherapy. So you had a wide heterogeneous variety of different types of chair, different types of department, with a kind of assortative mating, selection of those resident candidates interested in a more biological approach going to certain departments, those interested in a more psychodynamic psychotherapy or cognitive behavioral approach going to departments that were friendlier to that.
You throughout most of your career, had your foot firmly planted in the psychotherapy camp and in empiricism. I mean, from Cornell and Langley Porter and Duke. What was it like?
Well, the departments that I both worked in and then led had very extensive psychotherapy training. So at Cornell, Columbia, and Duke, the three departments I worked at, we gave the residents lots of psychotherapy training. We provided them with very good cognitive behavioral, psychodynamic, family, in early days group supervisors. And the residents came out. It's not that hard to learn how to use meds. It doesn't take a genius to learn how to use psych meds. So for residents in those programs that were sympathetic to it, psychotherapy training was a major part of their training. And residents everywhere want psychotherapy training. Psych residents want psychotherapy training in almost all the programs. Some programs had a modified form of that with some training, but not the full blast that we would give them. And some programs made clear they weren't that interested in psychotherapy training. They saw the psychiatrist's role mostly just giving pills.
Well, I remember...
Or doing research.
Yeah, I remember you invited me to give a workshop to the residents. I don't remember the year at Duke. And they were very receptive, very, very interested.
Even now, I get invited by psychiatric residents in different places where their programs are less psychotherapeutically oriented to speak to them about psychotherapy and its role in psychiatry. So I think that I don't want to paint a picture of psychiatry now just being pill pushers. I think that by and large, psychiatrists now have much less time with their patients. And the thing I emphasize to them is that every minute's precious. That you're not just, if you have 20 minutes, you're not just writing a prescription, you're not just checking the symptom pattern and diagnosis, you're not just checking for side effects, you're doing psychotherapy. And I told you about a paper that my friend Ono wrote here, but also in Japan, called Zen in the Art of Psychotherapy, with the idea being that every moment with a patient has the potential to impart psychotherapeutic insights and to change a person's life, that we don't restrict. No doctor, it shouldn't be just psychiatry, every doctor should be trained in psychotherapy. If you're an oncologist, if you're a family practitioner, a lot of what you're doing is psychotherapy, and we shouldn't see psychotherapy as something that's only done in a 12-session or 12-year formal setting. Psychotherapy is part of every contact with a patient, every clinical setting.
Well, aren't there data to show that if the relationship between the physician and the patient dealing with a medical problem is good, the outcome is likely to be more positive? They'll take meds, they'll do what they need to do to take care of themselves.
Exactly. And then what happened in psychology was kind of parallel to this, that psychologists fought very hard in the 70s, 80s, and 90s to get prescription privileges. They had powerful allies in Congress, but the effort by and large failed, I think in part because of lobbying by psychiatrists, but also medication was being given out too liberally anyway. Psychiatrists were giving too much medication. Primary care doctors who give 80% of the psychiatric medication prescriptions were giving out too much medication. And I think that there's a real fear, certainly my attitude was that there was a real fear that if you allowed everyone to give out medication, we would be flooded even more. At this point, 20% of the population takes a psychiatric pill on a regular basis. If psychologists could prescribe pills, this would go up and be kind of ubiquitous. So what psychologists did instead was to emphasized the value of psychotherapeutic approaches, and research supported that made very clear that for mild to moderate problems, psychotherapy was equal to medications and had more enduring effects. So the psychologists were showing that psychotherapy was valuable, and then they made the crucial error that instead of saying that we have complementary techniques, that in some cases psychotherapy will be the primary treatment and medication only a last resort. In other cases, medication will be the primary treatment. Psychotherapy will be a useful adjunct. There became a war between the professions in which at least some psychologists, not the smart ones, but some psychologists took a very reductionistic approach that in order to protect their professional legitimacy, they had to attack the biological aspects of mental illness and had to attack medication. So that the more radical element in psychology switched from having a rounded biopsychosocial model to saying, oh, it's all problems are psychological problems or environmental stress problems, that the medical model has been oversold, and they went further in saying many of them that was discredited, and attacking medication rather than seeing the different methods as all being useful depending on the needs of a specific patient. No one method being necessary, no one method being for everyone, no one method being sufficient for everyone. And it's better to view the world from a broad biopsychosocial model than to be reductionistic.
Yeah. Well, within the history of psychology itself, there's the notion of the empty, quote, the empty organism, or the tabula rasa. John Watson saying, give me a dozen healthy infants and I'll make one a doctor, one a lawyer, and he can just shape up individuals. So I think there's a deep structure within psychology about that, as well as the professional turf to
I think it's a very interesting history of this. John Locke in the late 1600s talked about a blank slate, yeah. a tabula rasa. And the idea was the baby was born sort of without tendencies, and their tendencies were all the result of experience. That was completely shot out of the water by Darwin. So the idea that we have an evolutionary inheritance and that a lot of our behaviors are shaped not just by the genes we acquire from our parents, but genes that have been built into the mammalian structure for the last 200 million years. And that some of what we do now is the result of what worked 200 million years ago in the proto-mammals. The idea that we were born a blank slate was completely ridiculous. So I think that the people you just mentioned, Watson and later Skinner, who thought that they could manipulate all behavior just by environmental contingencies, completely missed the boat. Yeah. Just as biological reductionistic people who say, well, it's all in the biology and we just have to understand the brain and manipulate it with drugs, also miss the boat. That any sensible person, the trouble is there aren't enough sensible people, but any sensible person will say it's some interaction between nature and nurture.
Yeah, the
environment and current context.
The research on dispositional characteristics in infants, that was done, I forget the name of the person who did it. This is one of the side effects of old age. I started forgetting names, I think it was in my 30s. His early research showing that at birth you can determine the dispositional characteristics and that certain kids are behaviorally inhibited. Remember his name?
Yeah, we did last week a little bit. Jerry Kagan.
Kagan, right. There you go. But you're so much younger than me anyway, so I'm glad you got it.
And I knew the guy. That's part of why I remember it.
Okay, so you could see his face as a memory aid. I remember the original resistance on this. And people were saying, oh, no, it can't be. And then lay people who were parents would say, of course, our kids were different at birth. And I think there's a greater recognition of that. I mean, it doesn't negate the need for therapy because you could still, compensate for this.
Well, I think we've discussed any number of times how unfortunate it is that there's been such a number of schisms within psychology with all these 50 alphabet therapy names. It's also unfortunate that psychiatry and psychology developed from such different streams.
Yeah.
So psychology developed out of first laboratory experiments, and then a clinical field that was completely devoid of contact from medicine. And psychiatry developed out of medicine. And as a result, the two professions have been at war, both from a fundamental outlook point of view, and even more later from a professional who's going to get paid for what point of view. In the best of all possible worlds, some of the people I've worked with who knew medication best and best studied the biological aspects of mental illness were psychologists. That many of the people at Duke, at Columbia, at Cornell, many of the researchers who were most successful in studying brain function, and many of the clinicians who knew most about medication were psychologists, not psychiatrists. A lot of psychiatrists were doing psychotherapy, didn't know the first thing about medication. A lot of psychologists spent their careers understanding brain behavioral correlations. By the same token, some of the best psychotherapists I've ever known were psychiatrists. So that there isn't inherently something that says if you're a psychologist, you're going to be lousy about medications. If you're a psychiatrist, you're going to be lousy about psychotherapy. If you're a psychologist, you're going to be brainless. If you're a psychiatrist, you're going to be mindless.
Yeah.
There's nothing written in stone about this, but partly because of the competition between professions and partly because of the way insurance companies have worked, the tendency has been to split the two professions apart and to encourage reductionism when a broad-based biopsychosocial model is really what's best for patients.
I have another question for you, and that is, we're talking about psychiatry in the United States. Other countries psychiatry did not abandon psychotherapy, like Canada and some other countries as well. What do you think that was? Is it?
Yeah, Canada has a very different payment system where the individual provinces negotiate with each specialty. Partly as a result of their system, they had many, many fewer psychologists and social workers. So they even if they wanted to offload the responsibility and the expense of psychotherapy onto psychologists, there were many fewer people on which to do it. And the doctors maintained much more control over the purse. And it varies a lot from country to country. In some countries, there are the same kind of battles across professions that we have here. In some countries, there are battles within profession where you'll have more psychotherapeutically. In Germany, they have a whole group of psychotherapeutically involved psychiatrists who are in an ever sort of evolving competition, both with psychologists on one side and the more biological psychiatrists on the other. And it varies a lot country by country. It varies a lot by resources. So it depends on how much the total dollar is, and it also depends on who's apportioning it and who they're negotiating with, and also numbers. If you have lots of psychologists and very few psychiatrists, you'll get one outcome. If you have lots of psychiatrists and very few psychologists, you'll get another. So there are lots of local differences.
Well, psychologists did not have a very long history of doing therapy. It was a result of World War II and the psychological casualties of that got them to start seeing patients. What was it? That wasn't shell shock. What was it called during World War II? Battle fatigue.
Battle fatigue. Yeah, cardiac heart.
Yeah,
war neurosis.
Right. So there weren't enough therapists around, and the closest profession that had a number of trained individuals seemed to be psychology. You know about human behavior and emotion and things like that. So they were then brought into service as therapists.
I think that people now may not realize how young our professions are. Yeah. That in 1917, almost all psychiatrists worked inside hospitals. There was very little outpatient psychiatry. Now, very few work inside hospitals. Almost all of psychiatry is outpatient. And as you say, the psychology is even younger in producing a large number of clinicians. Psychology expanded much faster. So the typical psychiatric residency only had maybe 6 to 10, 12 people per year. and produced a number of psychiatrists that lead to the 40,000 that we have now, 35, 40,000 we have now. Psychology training programs were dispersed not just in medical schools, but all across the universities in America. There were many more universities than there were medical schools. So it was possible to produce a very large number of psychologists much faster. And I think the last time I checked, there were over 200,000 psychologists and maybe 200,000 social workers who do therapy, only 40,000 psychiatrists.
Well, we've just about run out of time, which in a sense was good because I was going to ask you to predict the future, but probably it's an unfair question. We don't know where the heck the professions are going or what the role of psychotherapy is going to be.
Artificial intelligence is the future.
That's right.
It's actually the present. It's happening more and more.
I know.
That might be a useful topic for next week.
If you know something about it, that sounds...
Can therapists be replaced by machines?
Okay. You lead the dialogue?
Robotherapy.
Well, until then, stay safe.
You too, Marv.
Talk to you then.
And everyone should enjoy doing psychotherapy while they can.
Okay, that's a prediction.
Bye-bye.